This session is about the importance of the completeness of myocardial revascularization and its evolving concepts. As surgeons, I think it's extremely important for us to make sure that myocardial revascularization is complete. As such, you increase the survival rates, and incomplete revascularization has been proven to have increased incidence of MACE and recurrent multiple events. The first speaker today is Professor Hamm from Nauheim.
Yes. Ladies and gentlemen, Mr. Chairman, it's a great pleasure to be here, join your meeting, and to talk about the completeness of myocardial revascularization and a little bit in focus on PCI. Now, if you treat patients with coronary artery disease, we have two therapeutic targets. That's first, of course, to improve the survival of the patient, and of course, on the other hand, to relieve symptoms, to improve the quality of life. And we have the two revascularization modalities. That's stenting and interventional cardiology, and then, of course, surgery. You know this better than I do. Now, with respect to the completeness of revascularization, we are happy to have a very recent meta-analysis, which includes 35 studies, although it's only one randomized trial, and it's almost 90,000 patients included in this meta-analysis with a follow-up of 4.6 years to tell us lessons about the complete revascularization. Now, interesting to note first is that, of course, CABG is doing much better in complete revascularization of patients as compared to PCI. However, it's not perfect. Only 56% of the patients are completely revascularized, whereas this rate is 25% with PCI. So it's much lower, but there's still much room, maybe, or potentially much more room to improve the completeness. Now, if you look at the pooled analysis, left for CABG and right for PCI, it's very similar. It seems to be a general law that if you achieve complete revascularization, the outcome is better. And here you see this for surgery, that there's an improvement favoring complete revascularization, and the same is for PCI. If you compare this, the mortality benefit of complete revascularization for CABG and PCI is very similar. You get about a 30 or 28% reduction in mortality if you can achieve complete revascularization. So it's a very strong driver to improve the outcome of the patient. Now, there's further evidence like this here from a registry which includes PCI patients from New York, and shows you over an 18 months follow-up that patients that have complete revascularization, that's the top line, have a better outcome. There's even a longer follow-up, up to 5 years following PTCI, and you see there's a 27% improvement in mortality if the patient is completely revascularized by PCI from multivessel disease. Now, it's interesting now maybe to compare bypass surgery and PCI with respect to the different anatomy we find in our patients. And only in main stem lesions and maybe main stem left mains with single vessel disease, the incomplete revascularization is higher with surgery. It's the blue barriers, and in all other situations, the more complex the coronary artery disease is, the higher the PCI is less incomplete, so to speak. So, I mean, that's not a very surprising finding. Of course, the more complex the disease is, then surgery is just having much easier to achieve completeness of revascularization. But you may also look at the syntax score derived from the syntax study, and it's throughout all three terciles, the low risk syntax score, intermediate, and high syntax score, that incomplete revascularization rates were higher with PCI, and CABG is doing better with respect to completeness. Now, an interesting approach is to look at the syntax score at baseline as compared to the residual syntax score after PCI is done. And you see here, of course, this is the residual score, this is the baseline score, that there's, of course, a shift down. A lot of patients have 0 syntax score at the end of the procedure, but there are quite a number of patients that have a very high remaining syntax score at the end of the procedure. And this illustrated here for the PCI cohort. This is the low-risk population, intermediate syntax score, and let's see, high syntax score. And the lower the syntax score is, the more frequent you find at the end of the procedure a syntax score of 0. That means, in other words, the lower the syntax score is, the more you have the chance to achieve complete revascularization by PCI. And vice versa, if the syntax score is very high, then many patients remain at the end of the procedure with a very high syntax score. So, in other words, they are incompletely revascularized. Now, what does this mean for outcome? And the residual syntax score is highly predictive of the outcome for the patients, one of the main driver. And this is here all-cause mortality on the left and MACE on the right side. And you see the dark blue line, the purple line. You see the high event rate in these patients if the syntax score remained on a high level. And even in more detail, you see here the 3 risk groups or syntax groups: low risk, intermediate, and high syntax score. And it's not so much pronounced in the low syntax score, but already in the intermediate and high syntax score patients, if the residual score of syntax is high, then here the event rate in this patient population is very high. So another argument to achieve complete revascularization at the end of the procedure, not only at the time when the procedure started. Now, with respect to PCI, there are determinants that are responsible for a high residual syntax score, and it's not surprising what you find here. It's, of course, the very high baseline score, total occlusion, calcification, bifurcation, tortuosity of the vessel, and a low effraction rate. This is all the problems that where PCI is having problems and where it becomes complicated to perform with PCI. So that's, to my point of view, not surprising. But also in diabetic patients, it's an indication that you will end up at the end of the procedure with a high syntax score. So in summary, in stable angina, you should try to achieve complete revascularization, and scaffolding or stenting, achieving incomplete revascularization should not be the aim. Now, many of our patients are not having stable angina, but are presenting with acute coronary syndromes. There are 30 to 40% of patients having acute coronary syndromes. And here, it may be a different baby. You have to differentiate between non-STEMI ST elevation and the STEMI ST elevation. Now, with respect to non-STEMI, we do have some data here from the Acuity trial showing that there's a strong trend that mortality is lower if you achieve complete revascularization when the patient has a non-STEMI. Statistically not significant, but it's rather clear trend. If you look, however, at the myocardial infarction rate, then a statistically significant difference during the very early phase already, that the patient will benefit, has complete revascularization as compared to incomplete revascularization. This is the PCI cohort. With respect to STEMI, we have very clear statement from the guidelines, and primary PCI should be limited to the culprit vessel, with the exception of cardiogenic shock and persistent ischemia after PCI of the supposed culprit lesion. It has a 2AB recommendation. What is the evidence behind this? The evidence behind this is surprisingly rather low. We do have some studies like this study showing complete in blue versus incomplete revascularization in patients treated with primary PCI for ST elevation myocardial infarction, and you see that the survival with complete revascularization is much better, and these curves tend to diverge over the time. There's another study from this country here, and that's published last year, a randomized trial of preventive angioplasty, which is also kind of a complete revascularization in myocardial infarction, the PRAMI study. And the outcome of the PRAMI study, although was not many patients were included, just over 400 patients included in the study, is very clear, is that preventive PCI is of benefit to the patient. In other words, more or less complete revascularization is of benefit for the patient. Don't only go for the target lesion, but also try to treat also all other high-grade lesions. And here you see the results in detail. The combined MACE endpoint here was statistically significant higher in patients that did not have preventive angioplasty. And this was driven by myocardial infarction, and this was driven by repeat revascularization becoming necessary for the non-culprit lesions that needed to be treated during follow-up in the patient that had primary PCI. It's a little bit different in shock, and it's very difficult to perform randomized studies in shock patients, and we don't have that many data on shock patients. But from this registry that was carried out in Europe, we see that patients that have multivessel PCI in cardiogenic shock from myocardial infarction have a higher mortality, a higher death rate as compared to single vessel PCI. However, this was not statistically significant, but close to statistic significance. On the other hand, we do see that patients with cardiogenic shock that have complete revascularization successfully done, they really have a major benefit. It's a 74% mortality reduction in hospital if you can achieve complete revascularization and cardiogenic shock in these patients. And that's the major driver to achieve the benefit. I like to also add to my talk situations when I think that complete revascularization may not be necessary. And that's what we may call reasonable incomplete revascularization. I come back to this later in my second talk, talking about anatomy or function-guided revascularization or physiology-guided revascularization. I may add one other point, that's clinically guided revascularization. And at least in Germany, we are facing more and more patients that are rather old and presenting with acute coronary syndrome or presenting this symptomatic coronary artery disease. You see here from 2013, it's more than 45,000 PCIs were done in patients over the of 80. And in this age group, of course, prognosis, improving prognosis may be not the main target, but relief of symptoms may be the target that's more reasonable. And that's why I think reasonable revascularization should be the aim in these patients. And we do have PCI data in octogenarians, and you see that in these patients there's no difference. It's a small population, and it's partly from China, but their incomplete revascularization in these patients is of at least no disadvantage. So there may be a subgroup of patients, particularly in the elderly, when it may be considered to have incomplete revascularization. I'd like to share one case with you that I just have seen 2 weeks ago. And this is the patients we see regularly now. 83 years old, severe angina, at rest, depressed renal function, had a previous myocardial infarction, history of TIA. And this was the right coronary artery It was occluded here because this was his old inferior myocardial infarction a few years ago, and now he came with this circumflex lesion. And it looked like that we have no chance to open up the right coronary artery, and his culprit lesion was the circumflex. And this can be easily done by angioplasty, and it takes about 5 to 10 minutes, and that artery is fixed, and the patient is pain-free. That's incomplete revascularization, but I think it's reasonable incomplete revascularization in such a patient because the patient was for many years more or less pain-free with this occluded right coronary artery, and now is pain-free again when you treated this circumflex, and he's 83 years old and has depressed renal function. So the conclusion is, of course, you should go for complete revascularization wherever possible, but sometimes you have to live without incomplete revascularizations. Thank you very much for your attention.